Good afternoon, everybody, and welcome to Pediatric Grand Rounds. My name is Meg McNamara. I'm the Residency Program Director, and I'm here in place of Dr. Raphael Hirsch, our Department Chair, and Dr. Sundrain Van Schaik, who's our Vice Chair of Education, because unfortunately they're not able to join us today. But this is one of our favorite Grand Rounds. We already have a chance to hear from the residents about the QI projects that they've been doing in their continuity clinics. And so first, I'd like to start with the UCSF land acknowledgement. We would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And at this time, I'm going to pass the mic to Dr. Marta Kosinski, who is one of our general pediatrics faculty and the director of the continuity clinics over at Mount Zion. And Dr. Kosinski, take it away.
Thank you. Hello, everyone, and thank you all for joining today. As the new site director for the Mount Zion Continuity Clinic, I'm really happy to have this opportunity for our residents to present the quality improvement project that they worked on this year. But first, I'm going to introduce Dr. Jocelyn Nolasco, who is the medical director of pediatric primary care for our West Bay clinics. She is also the director of quality improvement for those clinics. And as such, she's going to provide some background for the project that was chosen to work on this year. After that, our residents will present the project and their findings. And our amazing residents presenting today will be Tracy Barnes, Ryan Fox-Lee, Reed Hauser, Bella Lopez, and Justin Overall. Jocelyn, go ahead.
All right. Yep. Thank you so much, Marta. And I agree with Meg that this is also one of my favorite Grand Rounds because we really get an opportunity to applaud, just a little bit of applause for all the hard work that the residents do. So I think it's always a pleasure to come and talk here. So I wanted to discuss, do you mind just advancing to the objectives, whoever's advancing slides? Thank you. Yep. So the objectives here are for the project that we're presenting, not necessarily this talk. And the objectives of this project is to illustrate how our residency program and primary care clinic system have been able to come together and teach fundamental QI skills while collaborating with faculty, staff, and residents in our clinic to identify and work on a practice-wide QI project. Additionally, while accomplishing the above goal, we've been able to advance the quality of care for our youngest patients while considering and addressing health disparities. Can you advance, please? So these are listed, some of the objectives of the residency QI curriculum. I won't go over them in detail, but they're listed there on the slide. And just very basically, we apply lean methodology and teach A3 thinking through various teaching sessions throughout the year in our continuity clinic, specifically the very beginning of continuity clinic, and then check in regularly around progress towards our clinic goal. Advance, please. Can you move forward? Thank you. Yeah. So, So for some historical, no, sorry, go back one more. Where did the historical context slide go? I just saw it a second ago. Maybe, oh, there we go. Sorry. Yeah, perfect. I'll go back to that. Well, I think maybe they got switched somehow. For some historical context, we had been doing quality improvement projects in our continuity clinic for many, many years. Most of them were pod-specific, individual pod designed and picked. And we moved in the academic 21-22 academic year to a clinic-wide project where, like I mentioned, we are collaborating with the clinic leadership and faculty and staff. On the right there, you'll see some previous areas of focus, and some of these listed are the individual pod projects, and some of them are the more kind of overarching clinic goals. So the most recent one was that last one there, the MITRE activation in our limited English proficiency patients, but we've also done developmental screening, and then you can see there a vast array of various topics, which are all really still important to consider and keep working on. And then to give you a little bit of background on our clinic, if you don't mind switching back. Yeah, there we go. There's 46 residents assigned to our Mount Zion clinic system. There are 9 residents per pod, and per pod, meaning like each day of the week, there are 2 to 3 faculty assigned to each pod, with 2 being there at any given day. We provide care 5 afternoons a week, so Monday through Friday. And then in addition to our residency faculty teams, we also have the team, front desk team, MAs, LVNs, RNs, administrators, and all of our social workers who are also deeply committed to our projects. And yeah, thank you. And so this brings me to our current project. So we chose early childhood well visit attendance as a project to focus on this year. For various reasons, we noticed lagging rates in our attendance of these visits. And specifically, we were looking at early as in 0 to 15-month well visits versus kind of toddler years, which is also something we track, but we chose the 0 to 15-month as an age to focus on because of sort of the rapid growth and development and surveillance that we do during those visits, and opportunities for early referral, both to specialists and if there are any problems arise to GGRC and other developmental services. Also, it's an opportunity where we support breastfeeding and introduction of solids, provide important social supports, and then help with adhering to the childhood vaccine schedule. As you know, the vast majority of childhood vaccines are given in those first 15 to 18 months. And then also just the importance for developing trust with our providers in that period. And we do know that and not to spoil too much, because I know the residents will touch on this, but we do know that there are some disparities in accessing this care, specifically in our younger populations, both along racial and ethnic and also insurance payer type lines. And importantly, and not to sort of forget, we as a health system, we are eligible to receive incentives to improve these rates, specifically for public insured. So to kind of to put numbers to it, we have about $500,000 in incentive for 0 to 15 months and another $500,000 for up to 30 months. So it's a good chunk of money. Please advance. And then I want to just give a quick, I don't want to have you focus too much on the data here, because this is just meant to be an overview. But you can see here, this is data for our 0 to 15 months well visits, and what we consider to be an attainable goal, or a hopeful goal, would be 6 visits. And for those of you who do primary care, or if you haven't done primary care in a long time, 8 visits is the number that is generally recommended by the American Academy of Pediatrics in those first 15 months of life. And so we felt 6 visits was gave people some wiggle room there. And this is our overall population, so general population, which we have about 15,000 patients assigned to us at Mount Zion, with 40% of those being Medi-Cal or publicly insured. And our rates right now, as you can see, around 73%. And then on the right, you can see it broken down along racial and ethnic lines. And we have, as you can see, disparities glaringly there. Our Black and African-American families at 52%, our Native and Hawaiian families, although it's a low end, is at 6.7%. And there's definitely a lot more rich data we could look through there, but again, as an overview. And then drilling down a little bit more specifically to our publicly insured, do you mind advancing? This is my last slide. If you look at our publicly insured, we definitely have, compared to our general population, which also includes our publicly insured, we have a much lower rate. So as you can see, we're hovering in the sort of high 50s to low 60s there. And this is data from last May up until November of this year, or of this academic year. And this target you see here at 67.6 is the target for those incentives that I mentioned before. And this is where we brought the project to the residents and asked them to solve all of our problems. So with that, I would like to allow the residents to tell us about their project.
Howdy, y'all. My name's Reed. I'm one of the R3s here. So kind of following up on what Jocelyn or Dr. Laska was talking about, over the first 15 months, there are 8 visits that we have routinely scheduled: 2-week, 4-week, 2-month, 4-month, 6-month, 9-month, 12-month, and 15-month, with our metric being trying to help people attend at least 6 of those 8 visits, which is our goal. Interestingly, when we were looking this up, a lot of insurers recommend 6 visits as well, or say there are only 6 visits during this time. But our goal is trying to get to 6+ visits for our population. So something we noticed is that towards the winter and fall of this past year, we started to see a downtrend in our overall clinic performance of achieving this goal, which is something that was setting us up for how can we study this, how can we intervene, how can we improve this for our population. So our group as a whole decided to make a modified approach through a modified A3 quality improvement framework. We say modified, and we'll kind of get to this more on the next slide, just because some of the limitations we'll discuss later. This is an incredibly time-intensive process, and you need time not only in labor, but also overtime to be able to make these improvements. Ryan, do you mind going to the next one? So we identified our problem and saw that we were having a decreased rate in compliance or ability to participate in at least 6 of these visits, which was the study. We recognized a target metric, which we'll talk about with Bella in the next slides. And then our gap analysis was an intervention where we provided surveys to families to understand what were the barriers to this happening. We started to contemplate an experiment, but did not have time to truly develop an experiment or an intervention. And then we've started following results over time, but don't have the exact idea of the plan, do, act, study model, just based on limitations of our overall time within a year to be able to perform and complete a total QI project. But that's kind of the foundation of our modified A3, which I imagine will eventually turn into a complete A3 when there's over a year to actually fully implement and study the interventions. So next, I'll turn it over to Bella.
All right, hey y'all, I'm Bella. Thanks, Reed. So next I'm going to transition and talk about our problem and current state. So first off, essentially our clinic at Mount Zion has noted disparities in the percentage of patients who are able to attend the goal number of well-child visits. So our goal 6+ out of 8 of the first fundamental visits. And it's based really when you split it down the middle on socio-demographic factors. So listed there are race and ethnicity, language or English non-primary language, and insurance type. So here, so as of January 2024, this is kind of looking at, again, a modified chart of what Jocelyn had shown earlier, essentially a lower percentage of Black African American at 55.6%, and Native Hawaiian or other Pacific Islander at 50%. Patients had obtained the appropriate number of well-child visits or checks compared to the overall Mount Zion pediatric population. So there in the chart, you'll see that the dotted line represents where we would like them to at least be. And then as you can see, Black African American and Native Hawaiian or other. All right, and then another problem or current state is the disparities down language as a metric. So there's a lower percentage of patients with non-English preferred language that attained the appropriate number of visits compared to English speakers. So that's 54.8% versus about 71%. And then lastly, insurance disparities. So there were a lower percentage of patients who were Medicaid insured or had another publicly insured insurance who obtained the appropriate number of well-child visits versus those with private insurance. All right, now I'll just turn it over to Tracy.
Hello, I'm Tracy Barnes. So for our project, looking at our SMARTY goal, these are our goals that we made for our project with the lens of thinking of something that's specific, measurable, attainable, relevant, time-bound, and most importantly for our group, inclusive and equitable. So we had 3 target goals that we had compiled for this project. So for all of these things, our goal was by May 2024, so last month, we were hoping to increase the percentage of these patient groups by 10% for the number of appropriate visits that they had attained in the first 15 months of life. So our groups were Black and African American patients, as well as Native Hawaiian and Pacific Islander patients whose preferred language was non-English, and patients who had Medicaid or other public insurance. Now I'll turn it over to Justin.
So hello everyone, I'm Justin overall, also one of the R3s.
So now we're going to switch over to understanding contributors to the problem, which is a original part of the A3 framework, but we'll talk a little bit about that modification as Reid was mentioning earlier. So here is an example of the fishbone diagram, which is essentially a process or a visual framework to help QI interveners think about various root causes to an issue or a problem. So as you can see on the left side, we have our cause and effect. And typically this process encourages you to think about various domains, for example, equipment, various processes related to an outcome, the people who are involved, whether that's people within the environment, the population that you're trying to or hoping to impact, materials or resources, environment, and then management. And so for our project, we really focused on not necessarily thinking of people as a root cause, but really centering people, namely our patients and their caregivers, in order to understand this problem. And so just as Reid was mentioning, we decided to do that in the form of a survey that would aim to essentially understand the barriers that might impact a family's ability to be able to present to clinic for these well visits. And so we provided caregivers with who are presenting for any of their 2-week to 15-month well visits with an open response 4-question survey. Again, these questions aim to understand any factors that contributed positively. So looking at supportive factors, as well as any barriers that impacted their ability to attend. And ideally, our hope was that we would be able to administer these surveys, not just to everyone, but really thinking about how to capture the population that is most affected by the inequity. Of course, understanding that for those who aren't able to present to clinic, being able to obtain this subjective information and insight is a challenge. And so, as you can see on the next slide, we had a survey period between January 4th that extended through February 24th. And within this time frame, there were 350 2-week to 15-month well child visits. And of note, this was scheduled specifically during resident continuity clinic time. So this does not include attending only provider visits that were scheduled at other times throughout the week, just the half-day afternoons in which residents were in clinic. And of those 350, 339 patients presented to clinic during that time frame. 11 scheduled patients were unattended visits, or those who were not able to present to clinic. And then of those 339 who presented for those well visits, 35 caregivers were surveyed. So about 10% of the population that we were able to capture in person. And so here's just a screenshot of what the survey looks like. It was a paper survey that providers would typically bring in at the beginning of the visit, and then amongst the many other forms that families fill out during this time, were given the opportunity to fill it out at some point during the visit. There's just a prompt that explains the objective of collecting the data and the 4 open response questions, which as Reid highlighted, and we'll talk about this more in our limitations in English, asking them to evaluate how many visits they might have missed during this time frame to their knowledge, factors that contributed to your child successfully attending those visits. What are some of, question 3 was, what are some of the reasons why or challenges that may have contributed to your child not being able to attend those visits? And then based on your answer to the, or other experiences, what are ways that you think our clinic can improve or better support families' abilities to help their child attend those recommended visits? And I'd say that last question was along with question 3, were probably the most impactful to informing our future directions. Okay, and with that, I will turn it back over to Tracy to review some of the demographics.
Okay, so this is the demographic data that we collected from the surveys that were handed out and off of the patient's electronic medical records. So in terms of the demographic data, I think this is one of our more important slides and one that was more impactful in terms of how we decided to move forward. So if you look at completed surveys, and these are patients that were able to be seen and discussed with, the majority of those patients were white or other, which is a broad category, but the majority were white. And then out of our 11 unattended visits, the majority were Black and other. In terms of ethnicity, whether folks were Hispanic or Latino or declined to answer, there wasn't a lot of differences, and there was no significant differences in these populations. And again, we're seeing that in terms of those who completed surveys versus unattended visits, we don't see any significant difference. And I think this also lends into some of our limitations that we will discuss a little bit later. And I will give it to Ryan to discuss the results.
Hi, I'm Ryan Foxley. I'm one of the R3s, and I'm going to talk about the results of the study. So question 2 of the survey asked about factors that contributed positively to successfully being able to attend well-child visits. Generally, you'll see in these results kind of broad categories of like logistics, like transportation, affordability, scheduling, I think, are kind of the broad things that I saw. But the specific ones that we saw, saw in the results that were most likely to contribute to successful visits were having flexible work leave, or caregiver work policies, access to transportation to get to the visit, and that there's a convenient location, that it was close enough to home that people could get there. In terms of barriers, the largest thing answered was blank. People weren't necessarily able to identify, but those that could, work responsibilities and distance from home were the number, were the highest number, followed by transportation, and then it kind of drops down. In terms of recommendations, not everybody had suggestions, but it does kind of come back into similar to previous of hoping for more affordable parking, for validation for parking, getting reminders to make sure that people were aware of the visits, and having more availability just in terms of after hours appointments, weekend appointments that people could make. Now, we also looked at changes over time. So what did we learn from that? In terms of looking at racial and ethnic disparities over time, I think, and I'll just point these out to you, and then we'll kind of come back to look at what the trend is. But the notable improvement here is under Black and African American patients. We saw an improvement from January to April in well-child visits on its own as we were looking at the data. You'll also notice the other disparity that we talked about was in those bar charts earlier, the Native Hawaiian or other, or yes, Native Hawaiian or other Pacific Islander. That kind of comes down. Keep in mind that is a very low N and isn't necessarily something that we can draw a lot from. I think we had an N of 2 for that particular line. In terms of language disparity, over time, we saw that primarily non-English speaking patients, there was a drop from 54.8% to 51.4% over the 4 months, while primarily English speakers, it improved over those 4 months. And in terms of insurance, it actually, along private, other public, and Medicaid, when we divided across that, all of them improved across the 4 months. So this kind of just summarizes what I just showed you, that the rate of achieving our well-child metric improved for both Black and African American and Native American, other Pacific Islanders, which without a widening of the gap compared to Asian and white / Caucasian patients. Language disparity worse for non-English preferred language patients compared to English speaking, and rates improved for those with Medicaid, which is one of the things that we were following, without evidence of worsening the disparity compared to those who are commercially insured. And I think for our limitations, I think Reed will be coming up to discuss those.
I think one of the biggest limitations is noting that our most at-risk population is those who are non-English as a preferred language, and these surveys were only offered in English based on limitations to funding and other resources that we had in our QI project. Additionally, these surveys were only offered to individuals who were in person for their visits, which means that they were able to overcome whatever barriers may exist for families who are having more difficulty attending these visits. So that fundamentally skews itself to the population that we are surveying away from those which we're most interested in. A thing with our resident clinic is you naturally have a lot of variability in which provider you see, and you don't get as much continuity with your providers. So some families feel a little bit less loyal to those clinics and seek to either migrate into or out of our practice, looking for more consistency with the providers they see. So over time, patients will leave our clinic, and those patients are really difficult to follow over time. So they may be meeting those metrics at other clinics or across multiple clinics, but we have no way to track that data, and it's very difficult to see who's left our practice over time. We also fundamentally, as residents, have very limited time for a QI project, and anyone who does QI knows that it takes a lot of time, it takes financial resources, it takes physical time, as well as time across a year. So our program, fundamentally, our intervention was this survey to understand the needs and the gap analysis of how are we not meeting the needs of our families. We did see some improvement for certain populations, as well as some decline for other populations, but there was no true intervention. We were just establishing our baseline for possible interventions for taking this work further. And fundamentally, just our time as residents, we had, I think, 5 or so sessions to actually be able to work on this. Potentially the limitations within the current model of the standardized extended continuity clinic versus considerations of switching to an X+Y model. There might be more dedicated time for residents to be able to focus on a project like this in the future. And for the next parts, I think I will turn it over to Justin to talk about where we currently are.
Thank you, Reed. And so now switching over to our current status or current state. So before I jump into the slides, so as Dr. Hauser mentioned, we weren't really, we obtained some valuable data, understanding that there are important populations who we weren't able to capture. Despite this, there is some information that we did receive from families that started to spark some ideas on potential interventions moving forward. And so one of the first ideas, as was captured in question 2 and questions 4, were thinking about transportation. And so one thought that came up is potentially increasing the knowledge of transportation resources. So for example, for those who don't know, for families who have Medi-Cal, there's actually a transportation benefit where folks can call their designated Medi-Cal office to pre-arrange travel to and from any healthcare visit. We talked about potentially disseminating this resource in the form of flyer, sending out via MyChart, also with that acknowledging that MyChart access is also quite variable and that there are inequities in access to MyChart, which have been discussed in prior years, this year as well, including with our colleagues at SFGH, and also potentially disseminating this info via USPS mail. We also, oh, yes, sorry.
Are all your patients from San Francisco?
That's a great question. So and maybe Dr. Nolasco will be able to speak to the exact percentages, but we have patients from all over the Bay Area. I'd say the majority of our patients live on in the West Bay, like this in San Francisco and the Peninsula, but we do have folks who were either born at UCSF or their parents or caregivers might have been born at UCSF and will travel distances to see us. But we do have quite a mix.
We do. I will say though, for our Medi-Cal patients, because San Francisco Health Plan is a San Francisco County only plan, those patients are typically from San Francisco. It's our private pay that may have a broader reach.
Excellent. Thank you, Dr. Nolasco. And so in the spirit of collaboration, we discussed working with our social work team and other individuals within our clinic staff to make sure that the list that we gave them was comprehensive. And then that last bullet point really highlights some of the challenges of this resource. While potentially not widely known, is also not a perfect resource. And some of we did have some residents from our clinic who, of course, before disseminating a resource, it's important to vet it and see what the experience is like from the patient and family end. And we had residents call several of those numbers, call multiple times and kind of be on an endless loop and not actually get anywhere. Some of the other limitations of this specific resource that our social work team has highlighted is that it's very strict as far as the use of the resource. So the way that it works is that I think it's either a taxi or a ride share will be scheduled for the patient. It's also pretty strict in that the ride share or arranged transportation option might not be on time, which can impact a patient's ability to arrive on time to their visit when they have one. Similarly, if thinking about the end of the visit when the patient is to return home, if for some reason the visit is running late and the patient is not outside at the designated time, that the arranged ride is to pick them up and bring them to their next destination, they will then leave, and kind of that leaves the family in a position where they might be stranded and unable to return home after the visit. Similarly, another resource is the UCSF shuttle system. So the same shuttle that many of the faculty, residents, students, and staff within UCSF use to get between various campuses, also is available to patients. This also might be something that's not widely known. And one thing is that we have heard that at times, if patients don't have on them any proof that they have a scheduled visit, they might be denied access to this shuttle. So if they don't have a smartphone or a piece of paper that shows that they have a visit, this can be very prohibitive. Another response idea that was highlighted actually in many of the items through the suggestions in various ways, many folks brought up wanting additional hours or more times to choose from, more times or availability outside of employment. And so the Office of Population Health has also recognized this need and has been working to establish a Saturday clinic where there's this community center called Southeast Community Center. And the Office of Population Health had been screening for eligible patients living within a certain mile radius of the Southeast Community Center. And their goal was to complete around 24 well-child visits for San Francisco Health Plan or QIP patients. So those who had maybe gotten behind on some of their healthcare maintenance due to various barriers, and also prioritizing again those in certain neighborhoods nearest the center. And this was something that they were hoping to launch on June 16th, but they noted kind of system-wide many barriers and challenges with launching this, including provider availability, finding adequate staff to support, including nursing staff, MAs, LVNs, as well as supply availability, including vaccines, which, as we know, is a significant part of the primary prevention and healthcare maintenance during the 0 to 15 month time frame. And so I think this is still something that hopefully the Office of Population Health is continuing to prioritize as a potential intervention to support families. And so in conclusion, kind of highlighting some of our big takeaways is just as Tracy mentioned, that those who were most affected and impacted by inability to attend well visits were largely patients of color and those who do not have English as their primary language. As we mentioned, potential interventions that might be considered for longitudinal work is increasing knowledge of transportation options, having after hours for primary care, including Saturday clinics, And then other future directions, very importantly, as Dr. Hauser mentioned, is translating the survey into multiple languages. We acknowledge and celebrate the fact that Mount Zion has a very diverse patient population, and it's important to be able to capture those needs adequately. And continuing to evaluate the impact of interventions, hopefully having time for more longitudinal work, potentially starting the QI, introduction to QI earlier and the brainstorming process earlier to allow more time for longitudinal follow-up. And like Reed mentioned, thinking about creative models outside of the current QI framework to allow more flexibility with the timeframe of the project. We also, again, want to reiterate the importance of identifying and evaluating those patients who are unable to attend, which highlights that next point of really utilizing our resources, including the Office of Population Health, to figure out the best ways for more meaningful outreach to these families, and especially one that has an equity focus. And then lastly, from a QI framework, thinking of the challenges in a single QI intervention, especially one that's resident-led and resident-driven, understanding the time constraints and just the magnitude of an issue that is complex, that can't really be narrowed down, especially when it's something that's based on systemic structures or systemic challenges, structural challenges, including institutional and structural racism as root causes for inequity. And with that, I believe that concludes our presentation, and we welcome questions, dialogue, and feedback.
If people have questions who are on the Zoom, feel free to put them into the Q&A into the webinar, please. And I'd be happy to have that. It looks like Glenn, you have a question?
Thanks for sharing this, and sorry I missed the first few minutes, so if I asked something that you answered, I apologize. The first is two comments. One is with respect to translation services. More and more with improvement work and patient education materials, interpreting services is telling us they want to do that for free. So cost shouldn't be a barrier if it's something to directly improve patient care. There are surveys. Then when I was an intern, we did a pilot of evening clinics as an alternative to Saturdays, if that's something you're thinking about. My question to you, as someone who doesn't do primary care, is to what extent are televisits and video visits a solution? I don't want to provide a different level of care just because it's more convenient for patients, but are they viewed as equivalent care? And if so, is that an option?
Yeah, so that's actually a great question. And I think especially for Dr. Nolasco and Dr. Kaczynski and many of us who were also just thinking about telemedicine and the way that we responded during the pandemic, we did recognize that during that time frame, there are some things that can be appropriately addressed via telemedicine, one of those being the 1 month visit. So definitely more so during the pandemic. That's not a visit where infants are usually receiving any routine immunizations per the CDC schedule. And so depending on the family, those would often be offered as a way to have a check-in, not necessarily need to be waived during that time if there were no feeding concerns or prior concerns for growth restriction or growth challenges. And so I think for that age group, at least, it was something that was accessible, but then thinking about the other time points, like the 2 month, 4 month, 6 month, 12 month, and 15 month, during which vaccines are administered, we would have to think about creative ways to address those opportunities. And then I think something else with like the art and beauty of primary care and being able to have that face-to-face, develop that therapeutic alliance and rapport, and also the physical exam element is something that's hard to duplicate. And then, yeah, would you like to come up?
One of our projects last year was looking at, oh, sorry.
Our project last year was looking at who was enrolled in my chart and who wasn't. So I appreciate the idea of doing more video visits because I think that could fill gaps for patients who ultimately aren't being seen. But part of the disparities that we were seeing is that the same patient population isn't necessarily signed up for my chart and wouldn't be able to access those video visits.
I have a question, and maybe you can repeat the question so that people can hear it. So I recognize that you had a very time-limited amount of time to complete this project, and so, but recognizing that the interventions need to be addressing what the root causes are. I'm wondering if there's been consideration about trying to do some sort of phone follow-up or reach out to the people who actually didn't show up, because they may have that may be more illuminating in terms of what the barriers are for that subset of patients in terms of addressing things that would be meaningful to phone numbers.
Absolutely. Thank you, Meg. Just to highlight that question. So Meg was acknowledging the time restraints component of barriers and I guess thinking of creative ways to perform that outreach for the population, the utility of telephone follow-up, specifically to understand those barriers for the targeted population.
I will say one thing, I recognize it is not a standardized format, but I think anecdotally, many of us, when we do have patients who are unable to attend visits, we call to see if they're still coming, call and see if there are barriers. So anecdotally, we have some things that my experience, most people just forget, despite reminder, my chart messages, despite calls on their voicemail. I know there are some families I've had that have had barriers to transportation. I don't think we have a formalized way to do it, but I think many of us do call to try and get insights from families at our current state. But it could be beneficial to set up a nursing call system to more formalize that or document it. So that way it could create metrics for improvement for a QI project.
Other questions?
Oh yeah, I was just gonna comment and say, given your outcome window is like a 15-month time frame, it would be really hard to show an improvement in this in a 5-month time frame. So it's very reasonable to like sort of carry this into a second year, just mathematics. Right? But I really want to commend you all in, despite sort of the constraints, taking such an in-depth look at the problem and the drivers, because most QI fails because people jump to what seem like, the most logical or obvious solutions or based on the anecdotal. And really bringing an equity lens to the work, like right from the start, and how you looked at the data and are thinking about.
I don't know, Jocelyn and Marta, were you able to hear those comments by Suni?
So Jocelyn and Marta, I don't know if we can maybe chat about being able to carry the project over into future years. It was something we had initially discussed at the beginning of this project, but I think you guys have a lot more information and insight into what that would look like.
I definitely think it's something we could do, especially because we have sort of learned history. There's, although you were all senior residents, all of the residents in each pod participated. So that information can certainly go forward. And I would also just like to sort of echo what Suni just said, is that you sort of took the heart of the A3, which is, I think the point of this A3 thinking is to keep us from identifying a problem and then jumping to a intervention. We hear there's a problem, and so many of us we want to solve the problem, so we go to that, and that's the way our brains tend to work. And you didn't, and you really got at some of the root causes. I thought that was pretty amazing and very valuable information that I think I hope does carry on.
Totally agree. I'm always really impressed and grateful for the work that you do. And I have a comment here from Dr. Sabrina Fernandez, who's another one of our primary care providers over at the General Peds Clinic at Mount Zion. And she said, I'm so impressed with the residents and their ability to gather important data and tease through these important issues. Well done. And she's been reflecting upon the importance of building and maintaining a diverse workforce that reflects our population, so that patients can really create meaningful bonds with their providers when they look like they do. And she's thankful for the affiliation with the East Bay Primary Care Group and the awesome innovations like the Bloom Clinic, and that we can learn from interventions that address like this exact issue. So, other questions or comments?
Can we have a round of applause for Justin too? Because she really ran this project.
Really do appreciate that you have limited time to do this as residents, and I appreciate Marta and Jocelyn for your leadership in this. And I also want to call out Suni Kaiser, who's taken on the QI curriculum for the residency over the past few years and has really ramped up some of the learning about lean and the systems that we use here within UCSF Health, as well as at the General and Kaiser, and all of the lean champions who are helping you with that. So thank you so much. And with that, I'll say thank you and enjoy the rest of the day.